Okay, well, let's get started. This is Deborah Lee. I want to welcome everyone to today's Woodlands Lunch and Learn. So we've got a very interesting session for you guys today. I'm just going to quickly introduce our speakers and go over the CME information, and then we'll turn it over, and you guys are in for a treat. So we have two speakers today. We have Dr. Franklin, who is a pediatric psychologist that specializes in using cognitive behavioral therapy, acceptance and commitment therapy, and motivational interviewing techniques to address adolescent mental health concerns, especially mood, anxiety, and eating disorders. Her research indicates interests include adolescent health risk prevention and intervention methods. We also have Dr. Ricondo, who is a board-certified pediatrician specialized in adolescent medicine. Dr. Ricondo graduated from UT Southwestern Medical School and completed their pediatric residency at Stony Brook Central Children's Hospital. Following a year as a chief resident, Dr. Ricondo completed an adolescent medicine fellowship through Baylor College of Medicine and Texas Children's Hospital and has since stayed on as clinical faculty. Their clinical interests and research interests include care of transgender and gender diverse youth, as well as management of eating disorders, gynecological issues, and sexual reproductive health needs. So the QR code is on the screen, but I'm going to move forward. We'll also have the link for sign in the chat. Just want to please encourage everyone to sign in and be sure to spell your email address correctly, because that's how you will receive the post-course survey at the end of this session today. One AMA PRA credit will be awarded for CME, and that can be obtained a week from today when the survey is complete and the results are in. And so you, once you sign in, you'll also get a copy of this disclosure that you can read over. But basically, our speakers and everyone involved in planning today's presentation have no conflict of interest to disclose in regard to any financial or commercial conflict of interest. So with that, I am going to turn it over to our speakers, and I believe Dr. Ricondo is going to start us off.
I think it will be me.
If that's I'm okay. So sorry.
No worries. Can I just tell you to advance through whenever I can I just say like next slide?
Absolutely.
Awesome. Well, I am Liz Franklin. For anyone who doesn't know me, I am the psychologist in adolescent medicine based up in the Woodlands, but I actually am on a team of 4 other psychologists in adolescent medicine. And I'm really fortunate for the opportunity to talk to you guys a little bit more about how to better identify patients that might be at risk with having an eating disorder, and just to better understand how we treat those patients in adolescent medicine, and what kind of signs and symptoms to be on the lookout for, and how you can get them into our clinic if you have concerns. So today I'm hoping that we can go through the DSM-5 diagnostic criteria for restrictive eating disorders, differentiate between different levels of mental health care for patients with eating disorders, and best determine the level of care necessary for their patient to be referred to us. And outline some recommendations for the level of care based on the mental and medical health symptoms. And hopefully one thing that could be really valuable about today is just demonstrating what kind of language and family-centered approach can be most helpful to actually get a family to follow through on a referral to adolescent medicine or to a psychologist, and briefly describe the most evidence-based treatments for adolescents with restrictive eating disorders. You can go to that next slide. So I'm going to first start a little bit about some statistics on eating disorders, because I think it's helpful to know how common these diagnoses are, and how frequently they are maybe going missed, and how dangerous they are. At least 30 million people of all ages and genders suffer from an eating disorder in the US, and every 62 minutes, at least one person actually dies as a direct result of an eating disorder. So that can be either from for physical reasons, because of malnourishment, where they can actually have a heart attack or pass out and die because of not getting enough nutrition, but also they have a very high rate of suicide as well. In fact, eating disorders have the highest mortality rate of any mental illness. That's something many people don't know about. So we take that really seriously, and we want patients to get help as soon as possible. The lifetime prevalence of eating disorders is 2.7%, and the mean age of onset is 18, but obviously we see a lot of very young teenagers and In fact, sometimes in our clinic and on our inpatient unit, we see kids as young as 10 or 11, and we see more and more young children suffering from eating disorders. Eating disorders are more common among females than males, um, but that actually is not the case with a specific type of eating disorder called ARFID, which we'll talk about, avoidant restrictive food intake disorder, which is actually more prevalent among males, with a prevalence of 3 to 5% of all children. Go to that next slide. So I want to talk briefly about these different types of eating disorders. I think most people, when they think of, what's an eating disorder, they think of anorexia nervosa. So AN is like people are aware of, it is a restriction of food leading to significant weight loss. So typically that's through extreme dieting, restricting food by fasting or excessive exercise. What's important about this diagnosis is it's not just restricting the food, they also need to have an intense fear of gaining weight or becoming fat, an intense desire to lose weight or maintain their weight, significant concern over their bodies, body dysmorphia, so they don't see their body the way that other people are seeing their body. And then we subtype that diagnosis depending on their BMI. And this is in contrast to a diagnosis that has actually just recently in the DSM-5 come out, but we believe obviously it's been around much longer than that, but became a formal diagnosis in DSM-5, and that is ARFID, or avoidant restrictive food intake disorder. Sometimes, and I especially think that sometimes GI physicians see kids with ARFID, and there's question about whether these kids have anorexia or something else. Oftentimes that something else is ARFID. So these kids are also not eating. They describe either avoiding the food or not being interested in the food, and they have significant nutritional deficiency because of that. So they're losing weight and they have nutritional issues, but the weight loss is not due to that fear of weight gain or fear of body image concern. Instead, it seems to be related more to a fear of something else. Oftentimes, kids will describe being afraid of choking, feeling like they're not going to be able to swallow their food because they may have had a choking incident. Sometimes I see ARFID when it comes to fear that the food is contaminated or gross in some way. I've had a patient who was very, very scared that food hadn't been properly cooked. So she was avoiding a lot of foods that could have been contaminated with germs or not cooked properly, so that they would have bacteria on them. So those kids all can appear like having anorexia because they're very low weighted and they're not eating, but their psychology or their kind of cognitive processes around why they're not eating are very different from anorexia nervosa. You can go to the next slide. Another common eating disorder that many people are aware of is bulimia nervosa. So bulimia is an eating disorder similar to anorexia, where there's an intense fear of weight gain or desire to change their body. But what the patient is engaging in is a combination of both binging and purging. So they're doing something to get rid of the excessive amount of food that they've been eating. So they're experiencing binge episodes, which is where you eat a large amount of food compared to others in a 2-hour window or less, feeling like you're out of control or you can't stop. That must occur at least one time a week for 3 months or more. But then they're also engaging in some kind of compensatory behavior to prevent the weight gain. Often that's purging, vomiting, but it can be laxative use, diuretics, or excessive exercise. And we determine the severity of bulimia by the number of compensatory episodes per week. Now, it's important to know that there are kids who actually meet criteria for anorexia nervosa binge purge subtype. So in that case, the patient looks maybe to others like they have bulimia because they might be purging or doing something else to get rid of the get rid of the food that they've been eating, but they actually meet criteria for anorexia nervosa because they're so low weighted. So what really differentiates a kid from having bulimia nervosa versus anorexia nervosa binge purge type is kind of the amount of weight that they have, their significant weight loss. So a lot of the kids on our unit, for instance, they don't meet criteria for bulimia. They would meet criteria for anorexia nervosa binge purge type because they're on our inpatient unit because they're suffering so much from a physical health standpoint with the amount of weight they've lost. What's often misdiagnosed or kind of underdiagnosed is a very common eating disorder called binge eating disorder, especially among kids who are overweight. So we think about restrictive eating disorders, but I do want to briefly describe binge eating disorder because I think it's something that can often sometimes later lead to restrictive eating disorders. And it's definitely a disorder that goes undiagnosed and is unfortunately hurting many, many children because it can lead to a lot of health problems as well. And that's where a kid has those recurrent episodes of binge eating, and they have to have 3 or more of the following symptoms. So they eat more rapidly than normal during those binge episodes, eating until they're uncomfortably full, eating when they're not physically hungry, eating alone or feeling like they want to eat alone because they're embarrassed, and feeling disgusted with oneself or guilty after eating. And in this case, they don't have any compensatory behavior. So they're not doing anything to get rid of the food afterward or prevent weight gain. And the severity for BED is based on how frequent their binge episodes are. You can go to the next slide. So unfortunately, there's all these eating disorders out there, and treatment is very poor. Less than half of all patients with an eating disorder actually seek treatment. 33 to 50% of eating disorder patients have a comorbid mood disorder like depression. And this is incredibly concerning because we know that these kids are already at high risk for suicide with an eating disorder. And then if they also are at high risk for depression, that can be concerning. And mood disorders are more common in the binge purge subtypes. So those patients with bulimia nervosa or anorexia nervosa binge purge type are definitely at risk. And 50% or more of all patients with eating disorders have comorbid anxiety too. So we're looking at OCD or social phobia. And in many ways, the anxiety kind of can feed the eating disorder and vice versa. So these kids really need help being able to manage multiple mental health conditions. And then we also know that patients with bulimia and BED are at increased risk of having substance abuse disorder, typically alcohol use. So we know these kids need treatment, and we know that treatment is poor. So we really want to think about how can we make sure they're getting the help that they need. Go to that next slide. So we kind of think about how do we identify kids at risk? What is the etiology of eating disorders? And I think the most important thing to know is it's incredibly complex. There's a lot of different factors, genetic factors, biological factors, environmental variables. So I want to briefly kind of go through what are these different factors. Go to that next slide. Great. So there's a bunch of different risk factors when it comes to having an eating disorder. First, genetically, we know that patients with a family member who had an eating disorder are about 7 to 12 times more likely to develop an eating disorder themselves. And biologically, there's actually been some really great brain imaging studies that have shown that people with eating disorders have altered brain circuitry that actually contributes to eating differently. So they have differences in their anterior insula, their striatal regions, and their anterior ventral striatum. And we know that there seems to be changes in how their serotonin pathways are when it comes to eating and their responses to food or to visual images of food. And so it might explain why there are certain kids who are better able to inhibit their appetite or seems to have issues with overeating, for instance. We also know that there's certain kind of temperaments or personality traits that go with eating disorders. So these kids tend to be, first I want to say in a positive light, wonderful. I love working with teenagers who have eating disorders, but I will say that some of those personality traits can be really difficult for them. So they tend to be perfectionist. They're very sensitive to rewards and punishments. They tend to have a lot of harm avoidance. Some tend to be impulsive. A lot of times parents will describe them as obsessive thinking or emotionally unstable or hypersensitive. So those kind of temperaments can also put a child at risk. In addition, we know that trauma is a major risk factor. Survivors of trauma often struggle with shame, guilt, and body dissatisfaction and a lack of control. And an eating disorder can often make these people feel like they are regaining control or coping with those intense emotions. Society and culture play a big role as well. Unfortunately, we live in a society that really highlights the role of social media, photoshopping things, airbrushing things, our idea of what the beauty standard is. Unfortunately, things like TikTok are readily available to teenagers where they can be edited and information can be shared in a way that probably isn't very honest and transparent about the realities of how our bodies look. And so I think what happens is people have a very distorted idea of what they should look like based on what they're seeing online or they're seeing on their phones. We also know that dieting behaviors and a dieting culture is also very dangerous. So, anytime you have a teenager or a patient that describes dieting, I think it's a major red flag. Dieting can often be the catalyst for heightened obsessions around food and weight. Almost all the kids I work with did not start with intense restriction. They didn't go from eating typical meals down to eating a couple grapes a day. It starts with dieting, specific small things that they were doing. I just wanted to be healthier, so I would cut out junk food. And then I wanted to be even healthier, so I would try to, eat less than 1,000 calories a day. And what's happening is that diet culture often creates more and more restrictions. You can go to the next slide. I also want to really emphasize that family isn't the problem. In fact, increased focus on the family is often the solution. Unfortunately, we know that stressful or chaotic family situations may intersect with other triggers to exacerbate or maintain an illness, but we know that they don't cause eating disorders. And the more that we can involve families, the more protective it is for the child to actually get better, and they have faster recovery and lower relapse rates. So we want to be really careful to involve families and help them see themselves as playing a crucial role in their recovery. Go to the next slide. So I want to briefly talk about treatments. And the main reason I want to talk about this is because if you ever have a patient that you want to refer to me or anyone on my team for mental health, I want you to feel like what we're doing is good treatment, evidence-based, and that we really know how to help a child with an eating disorder. So there are 3 types of evidence-based treatments. The first and most important type of treatment, especially for teenagers, is family-based therapy. It's definitely considered a gold standard treatment. And what we're really doing in family therapy is emphasizing a very strong parental alliance. I think this is hard because patients with eating disorders can often try to split their parents, or one parent is maybe on the fence more about the eating disorder and what to do. And it's helpful and important in family therapy to unite parents. Also, resolving family difficulties so that they can support the adolescents developing independence. Oftentimes, family therapy is really about helping the parents to understand what an eating disorder is and how they can talk to their child during a meal, how they can make sure their child eats. Most parents have no clue, and I don't expect them to, in terms of what to do when it comes to their child refusing to eat. They may say something like, I don't know, my child used to eat. Why would they not want to eat? I just tell them they have to eat. Some parents are saying they're trying to force kids to eat. They're pushing food in their face. They're threatening them around meal times. And we know none of that is effective. So family therapy is really about how can you talk to your child differently during a meal? How can you support them, but also hold firm boundaries? Now, individual therapy is often focused on cognitive behavioral therapy, or CBT. It's the gold standard for individual therapy. At Texas Children's, we are, in adolescent medicine, we are definitely all CBT therapists. We all kind of use and utilize other strategies as well, but CBT is definitely our base. CBT is really focused on these 3 pieces of our experience as humans. And those pieces are our cognitive factors, like how we're thinking about our bodies or thinking about the world around us. So, with an eating disorder, how can we start to change core beliefs about ourself, negative self evaluations? How can we start to challenge the idea of perfectionism? We also really focus on CBT on behavioral factors. How can we actually start to change diet behaviors, binge eating, purging behaviors, self harm, body checking, or body avoidance? So we are very specific on coping tools that patients can use when they have an urge to vomit or they have an urge to restrict, what they can do to get through a difficult meal. And what we're really also keenly aware of is that there are difficult emotions going on at all times when you're focused on how to change your thoughts or your behaviors. And so we also focus a lot on how can you accept difficult emotions and kind of ride through that, kind of thinking about riding like an emotional wave, without that wave kind of carrying you on to do something you don't want to do in your life. So CBT is going to be really focused on how to help that child individually. Another type of therapy that's really helpful, especially for patients with bulimia or other type of compensatory behaviors that they're engaging in, is DBT, or dialectical behavior therapy. DBT was originally developed by Marsha Linehan, and it was used actually to treat patients with self-harm behaviors. And where CBT emphasized someone's ability to change their thoughts and behaviors, DBT really focuses on emotion regulation, which is often a significant problem for patients with eating disorders. So, what we really focus on in DBT are these three components. The first is mindfulness, which is the idea that I need to be able to attend to things in the moment and to be non judgmental. Instead of being stuck in the past or worried about the future, how can I be more in the present? The other big piece is distress tolerance, or the ability to endure and accept emotional suffering by decreasing impulsive behaviors like self harming or purging. And the last piece is emotion regulation, where we really focus on how can I validate my experience and give myself some self-compassion, if you will, when I'm experiencing a difficult emotion. So often we do these types of therapy at any level of care. So if someone is outpatient, they're inpatient, or they're in what we call like kind of those medium levels of care, intensive outpatient or day treatment programs. So I want to talk a little bit about those programs. You can go to the next slide. And those programs are, from a lowest to highest level of care. The lowest level of care is something we offer in our adolescent medicine program, which is outpatient care, where patients are seeing their physician every couple weeks or months, and they're seeing a dietitian, and they're also getting therapy 1 to 2 times a week for individual therapy and 1 to 2 times a month for family therapy. Now, I will be honest, in our clinic, we have so many patients, and our psychologists are so busy with patients that we often have individual therapy once a week or once every other week. So ideally, they would have therapy more often, but it's often difficult given the volume of patients. Now, some patients just need more care. They need more help and support. So the next level of care that is available is an intensive outpatient program, or IOP. Usually these programs are 3 to 5 days a week for 3 to 4 hours of therapy a day. And that therapy is a lot of different things, right? It could be group therapy, individual therapy. Sometimes they have like a therapeutic snack there where they like eat together. One of the disadvantages at Texas Children's is that we don't formally have an intensive outpatient program. However, I'm proud to say, we have something kind of pseudo like that now. We recently, about 6 weeks ago, developed an intensive outpatient program that's virtual, where we offer therapy to patients that are just coming off of our unit returning home, where they get therapy 3 days a week for 1 hour after school from 4 to 5, and it's group therapy over telemed, so they can be at their house. They can come straight home from school and do therapy. And we are taking kids from the outpatient side to be in that program as well, who are really high risk of being admitted or having a lot of issues. And that program has been going really well. I think making it telemed is convenient for families across Texas. So they don't have to travel and leave school really early. I think they also like that it's after school. And that, unlike a true intensive outpatient program, it's not 3 or 4 hours a day, it's just 1 hour a day. So for a lot of families, that's reasonable and manageable with their kids' schedule. You can go to the next slide. Now, things start getting a little bit more intense when a patient is showing more and more signs of difficulty. So the next level of care that is offered is called a PHP, or partial hospitalization program. Sometimes people call it full day outpatient or day treatment. And this is a program where they get 5 to 7 days a week of full programming, usually from like 9 a.m. to 3 p.m. And that programming includes like group sessions, family sessions, individual sessions. They get snacks and meals there. Unfortunately, again, we don't have residential at Texas Children's, but there are many private programs or fee-for-service programs in the Woodlands. At least 2 programs, ERC, Eating Recovery Center, which is actually right next door to us in MAC 2. And then also Clementine is another program in the Woodlands that offers residential as well. So there are programs in this area. Unfortunately, patients need to have private insurance or be willing to pay out of pocket. These programs are wonderful in that they offer that moderate level of care, but I continue to be concerned about two issues, if I'm going to be totally honest. One is the lack of coverage. So a lot of families are paying a lot for these programs. And two, the level of providers is not quite the same. So none of these programs are really run by clinical psychologists like myself or the other psychologists that I work with in adolescent medicine. And they often aren't seen by a physician every day, the way that our patients would be if they were seen on the unit. So they do have physicians in these programs that see patients maybe once a week, but it's really nice to have that, kind of highest level of care with the most kind of like experts available. And I do think one day at Texas Children's, we're going to really work to build all these levels of care within adolescent medicine too. And so briefly, residential is just kind of like being in the hospital in the sense that it's 24/7, the kids live there, but they are not in a hospital. So it's more like a home, if you will. You can go to that next slide. Now at Texas Children's, not only do we have outpatient, but we also have inpatient level of care down at main campus. On the 14th floor, we have 24/7 care for our patients. All the meals are supervised. Patients are monitored in video camera monitored rooms to observe any binging, purging, or exercising behavior. They have individual, family, and group therapy at least weekly. There's a lot of meal planning and selection with our dietitian. And for many of these patients, it's an unusual experience because they're initially restricted to bed rest and they slowly progress to get PT and to be more and more independent around their meals. But oftentimes, this is the type of rehabilitation these patients need initially. So now that you know more about the different levels of care and about eating disorders in general, what do you do if you actually have a patient that you feel like needs treatment? And this is where it gets, I think, really dicey because I think a lot of physicians are in a position where they have patients who need treatment, but they don't know how to get that family to actually follow through and do what they want them to do. So mental health is sometimes a new concept for patients and families. There's a lot of uncertainty. There's a lot of patient resistance. There's a lot of different factors to consider. This idea of, blaming the patient or even sometimes other family members, like why are we having to do this? This is expensive. This is difficult. This is time consuming. Is this what we really need? Financial considerations. What is this going to cost? Are we going to really be able to do this financially? How long is this going to last? Many of our kids are on the unit for very, very long time, weeks at a time. In fact, many families are like, that's a really long time. I want my child there for 24 hours and then back home. And of course, there's often a lot of patient resistance. Eating disorders are tricky. Unlike depression and anxiety, where almost every patient I meet tells me they want to get better, they don't want to have depression, they don't want to have anxiety. Patients with eating disorders are not so sure. Sometimes they'll even tell me, I think that my life would maybe be better without this, but I'm also really scared and I really like being thinner and I'm really scared of gaining weight. So I don't really know if I want to get better. So what are we to do as a provider knowing that this kid is at risk, that they're in danger? What can we do? You can go to that next slide. We really want to take a family-centered approach. In a family-centered approach, we recommend that everybody has a role. The therapist role, or in this case, we could even say the physician's role, is to offer professional recommendation that is evidence-based, to act as a resource for that information, and to assist the family in considering their options, working through their concerns, and ultimately we're advocating for the patient, right? We're advocating for the client. We really want to take a non-authoritarian stance that is neutral and fact-based. The primary responsibility for the family is to ask questions and communicate their concerns. To really learn from a therapist or from the physician and through contact with recommended programs or with other clinics, to consider the feasibility, to communicate with their child, advocate for their child, and make the final decision. And really the patient, especially because most of our patients will be under 18, their job is really just to be honest, ask questions, and to communicate so that we can try to help them. Patients really are scared and they might say, I hate this, I don't want to do it. And although they may not get what they want, it's important that we hear them and that we continue to validate them. So I hear that you don't want to do this. And I also know that if you go home and you continue to not get treatment, that you could die and that your life could be seriously impacted by these decisions. And I'm scared of what that would mean for you. Asking their patient, what kind of life do you really want? And how can we make that happen for you? If you continue down this path, is there a chance that you'll continue to be able to have the life that you really want? You can go to the next slide. So your approach and behavior really matters as a physician. You want to take that neutral but firm stance. So we're being honest, we're being direct, but basing it on professional opinion and avoiding being emotionally involved. You also want to avoid an authoritarian stance of like, I'm the doctor, I know best, you need to do this. Because many kids think they know best and they don't really care what we think, even though, we may have all the right information, all the factual information. We also want to balance pros and cons. So maybe the family has thought of things you haven't with regard to the recommendation, like finances. We want to understand what are the barriers here to being able to follow through. Can I help you fix them? Is distance the issue? Can I find a way to get you transportation there? Can I work with social work around that? Is fear of what therapy is all about? Is that's what's scary? And also giving them time. Oftentimes this is an ongoing conversation. You want to plant the seed. Parents should not be expected to agree or make a decision right away, because that pressure is often something that kind of hurts that relationship and makes it so that the family doesn't feel safe. They don't feel like they can go back. Similarly, we want to avoid ultimatums unless that's been discussed at the onset of treatment, like during consent. We really want to not make it sound like we're going to lose my care if you don't follow through on this. Because oftentimes, again, families will just no longer come to see you or no longer be honest with you. Oftentimes, it can be helpful to consider involving other members of the team. So like a dietitian or a doctor, another type of doctor, for instance. Obviously, if they have a psychologist that they see outpatient, could you talk to them? Could you help them to help you have this patient get on board with therapy or going to a higher level of care? And we really want to make sure we're always maintaining a non-judgmental stance. So being able to say something like, I know this is a really hard decision and it's not mine to make. It is my recommendation, but it is ultimately yours. And I'm just open to the idea that you could consider it. I want you to be open to that too. And I want to understand how we can make sure that your child, or that you, if you're talking to the child, have the life that you want. And my fear is that if we continue to go down this path, are we getting closer or further away from that life that you want? And I want to make sure that we make a decision together that's going to be in your best interest. Really wanting to be gentle, to validate that they're scared or they may not want to do it. Those are important factors. You can go to that next slide. So I want to kind of close on my piece by just saying that, one of our big goals is that multidisciplinary decision making is really the necessary and appropriate way to recommend any type of higher level of care, whether that's like seeing no one to seeing someone for therapy, just trying to get an adolescent medicine appointment, or if it's like, I think that you need to go to the emergency room and you may need to be admitted to the hospital. There really is limited research on the short and long-term impact of treatment at these different levels of care. So I also want to point out that future research is necessary. We don't really know if patients need intensive outpatient or residential. We don't really know that. We do know that patients need outpatient care, and we do know that some patients need inpatient care. But I don't necessarily believe everyone needs to go through all the levels of care. So if you ever feel like as a physician, you're confused or concerned about what a patient does need in terms of those middle levels of care, you're always welcome to ask me or anyone on the adolescent medicine team what we think. But really, often patients don't need or aren't required to do that. It's just recommendations or based on, kind of what everyone else has been doing. And I think it's always important to remember that there are very, very significant financial, geographic, and evidence-based barriers to higher level of care options. And so when we consider recommending someone to something, sometimes we don't know the whole picture of what might be getting in the way for them, or it might make it difficult to follow through. And what I really think is valuable is family-based decision making. How can we meet a family where they are, collaborate with them, and really help them to see us as their advocate and on their team, instead of as somebody telling them what to do or telling them they're wrong? Because I feel like families are more likely to get help when they feel supported. So thank you guys so much for letting me have a couple things to say. And I'd love to turn it over to my colleague and wonderful physician that I work with, Dr. Ricondo.
Thank you, Dr. Franklin. So now that we've talked a little bit about how we kind of give someone a diagnosis of having an eating disorder or assign that diagnosis and the different levels of care, I thought we could talk a little bit more about like how do we evaluate these patients to figure out, is this the diagnosis this person has and where do they need to go from there? So next slide. So things that we want to keep an eye out for when we're evaluating a patient for a prospective eating disorder are a few kind of big warning signs. So like some big red flags that should pop up when you're having a discussion with a patient, right? So if the patient or the family member is discussing that they've kind of changed the way that they're eating. So that Dr. Franklin mentioned that oftentimes these patients will come in not having initially had severe restriction, but maybe just gradually starting to change their habits surrounding eating. Those can be red flags, right? Because especially if we start noticing that there's a pattern there in relation to how those restrictions are evolving, that's something we want to keep an eye out for, right? So is this patient no longer eating their favorite food, the parent might say, or they're not finishing the foods on their plate anymore, or they're eating less overall, or they no longer want to eat at the dinner table with the family. They're always going off to their room and eating by themselves, only eating late at night when the family doesn't see them eating. Have their choices surrounding food changed as well, right? So maybe before they were eating a very diverse diet and now they've said, well, now I'm vegetarian. And then from being vegetarian, they progress on to being vegan. Those are things that as culturally individuals can adopt in terms of diets, but when it evolves in the setting of restrictive eating, that makes us very concerned that are there specific foods that they're trying to avoid, right? Are they trying to avoid carbohydrates? Are they trying to avoid fats? Are they trying to avoid dairy due to fear of how those foods are going to impact their body, right? Other things that family members might notice are I noticed that they're dressing differently, right? They're wearing really baggy clothes. Sometimes this can just be due to like a lack of comfort with one's body, right? So wanting to conceal that or wanting to conceal the weight loss so that family members are not recognizing it. Things that you might notice in the office or in the hospital or in the ER with patients who might have an eating disorder are also body checking. So body checking is when an individual is trying to gauge essentially their size or maybe any progress that they're having in terms of weight loss, right? So that can come in forms of measuring their wrists with their hands or doing the same thing around their thigh. Some patients will use frank tape measures or use pieces of string and keep track of how much weight that they're losing or sizes that they're losing in terms of clothing. So sometimes when you'll notice if you're talking to a patient who has an eating disorder about some of these disordered eating behaviors that they have, as they become anxious during the visit or during the session with you, sometimes they'll start doing that when they become anxious or nervous, they might start body checking. That's pretty common. In terms of physical health changes, there's lots of medical complications that can arise secondary to malnutrition in the setting of an eating disorder. So one of the most common things that will present is a slow transit constipation and delayed gastric emptying, right? So oftentimes these patients will feel fuller faster, right? And so that can become a very vicious cycle. So for a patient who doesn't want to eat due to fear of weight gain, becoming very full very quickly can make them very concerned that, oh, I can see my stomach bloating now and I feel like I'm gaining weight, so now I'm going to cut back even further. And as they do and their malnutrition worsens, it can cause that delayed gastric emptying, so causing that initial cycle to worsen, but also leading to like muscular weakness throughout the body, right? So the person can become very fatigued, they might lose some strength, but their muscles kind of everywhere get weak, right? So like the muscles that line the intestines can get weaker, and so they can become more likely to develop a constipation, right? And so sometimes that may be what patients present with, saying like, I haven't had a bowel movement in a week, or my child hasn't had a bowel movement in 2 weeks, and I'm not really sure why. And part of that is due to that slowing, but part of it is if there's not enough food going in, there's not going to be a lot of stool that's going to be produced, right? When we think about muscular weakness, other muscles that get weak are the heart, right? So the heart is a very large muscle that our body has. And oftentimes these patients can present with pretty significant bradycardia or hypotension, right? Other things that patients might complain of are feeling that my skin has become very cold, specifically on like my hands or my feet, or the parents might notice that the color on their toes or on their fingers looks different. It looks like maybe pale or gray or blue, and it doesn't vary. It just looks like that all the time. That the patient seems cold all the time in general, right? It's 110 degrees outside and they're wearing a sweatshirt to school, right? They can develop changes in terms of hair. A lot of these patients will endure significant hair loss, but also development of like lanugo, or that fine downy hair, as a way of their body trying to regulate their temperature again when they've lost such a significant amount of adipose tissue. The other things that can come up are oftentimes rashes, right? So specifically at the corners of the mouth, we can see angular chelosis, right? When there are vitamin deficiencies that can develop, and just xerosis overall, so dry skin throughout the body, and the setting of like dehydration as well. But there's a number of complaints that patients may have, and our concern is when those progress to a point where now they're resulting in other medical complications, right? So if you become severely malnourished enough, if you draw blood work for this patient, are they going to have any electrolyte disturbances? Or if you do an echo for this patient, are they going to have a pericardial effusion now, right? These are all things that patients that with eating disorders, specifically AN, are going to be at higher risk for, okay? The other thing we want to check on is their mood, right? How have they been in terms of their way they're feeling, right? Because when you're struggling with an eating disorder and you have these fears that are very pervasive, it can be hard to deal with that and feeling like no one understands me. So oftentimes we're screening for things like comorbid psychiatric conditions like anxiety or depression, because as Dr. Franklin said, those can often go hand in hand with an eating disorder. So you want to make sure that you're asking those questions regarding depressive symptoms or anxiety symptoms or even OCD type symptoms, to see if that patient may have an underlying mood or anxiety disorder that has been present, and also asking time of wise whether those symptoms predated the eating disorder, right? So were they there even beforehand? Next slide. Thank you. So as Dr. Franklin said, what we're also making sure is how we're asking the questions, right? So when we're asking about all of these symptoms that patients may have or behaviors that may be they engaging in, we're asking in a non-judgmental way, in a way that we can try to kind of get to the source of what's led to the development of their presentation, right? So asking respectfully in a non-judgmental way, and making sure that we're not making assertive or judgmental statements in response to maybe things that patients have said. We're trying to gather all the information initially so that we can, again, make a recommendation for that patient. So things that we have to be aware of. When these patients are reporting that they're having these fears, it's also important to validate the way that they're feeling as well. Next slide, please. So what are questions that we can ask when we're evaluating anybody in terms of a youth who might be coming in who you're concerned may have an eating disorder? It's great to use open-ended type questions, because oftentimes it gives the youth or the young adult an opportunity to kind of really explain how it is that they're feeling, or how their symptoms or presentation has developed, right? So tell me more about what you are eating or drinking. What are your worries around eating right now? What are you afraid would happen if you did eat those things that you're saying that you are afraid of? So sometimes patients will describe foods for them as like, these foods I'm okay with eating. They're kind of like, they're green light foods. These ones I'm kind of okay. Like sometimes I'll have a little bit of maybe some cheese or dairy, but I don't like having too much of it because I'm worried about how that impacts me. And then these are foods that I don't eat at all anymore, right? And so what we're asking is really like, why are those other foods, like those yellow light or those red light foods, why are they in those categories for that patient, right? Are there reasons why they're particularly worried about those foods and how they might impact them, right? Is it because they're worried that they're going to gain weight? Is it because they're worried about their body's going to change shape if they eat more of those foods, right? And then asking about compensatory behaviors, right? So like, are they compensating for what they are eating with other behaviors like purging, whether it's through self-induced vomiting or through excessive physical activity, laxative or diuretic abuse. And we don't really see it anymore, but ipecac used to be used very commonly in these patients as a way of inducing emesis as well. So do you ever feel like you have to compensate for what you did in terms of like the meals that you have? Are good questions to ask. And then tell me what you like about your body. And so not focusing so much on the negative aspect, but if you ask a patient what they like and they can't even tell you one thing that they do like, that's another red flag, right? Asking about perceptions in regards to weight, right? So not only like, do you know what your weight is, or like, are you weighing yourself frequently, but how does that weight make you feel about yourself? Does it impact that person's perception of themselves, right? So if you gained weight, like how would you feel? Or if you lost weight, how would you feel about that? And trying to kind of get to the root of what is the emotion that's tied to that for that patient. Next slide, please. So when we're gathering information for these patients, if you recall from the diagnoses that we discussed, oftentimes we get we're trying to nail down what exactly is going on, right? And part of that can be related to figuring out how long these behaviors have gone on and how they've evolved over time, and the thoughts that are tied to them, right? So onset of behaviors is really crucial because like we talked about with diagnoses like bulimia nervosa, those symptoms have to be present for about 3 months and be occurring at least once a week over that period to assign that diagnosis to that person, right? And so asking about onset of behaviors and frequency of behaviors can be very helpful in helping you to kind of nail down what exactly this individual is struggling with, right? Because then that helps us figure out how are we going to treat that person, right? What treatments can we offer, whether that's a CBT focused approach or like a DBT focused approach, right? And are there medications that this patient may benefit from, right? So specifically for patients with bulimia nervosa who are really struggling with purging, medications like Prozac can be incredibly helpful in trying to inhibit those urges, okay? Other things that we want to be mindful of too are what is the impact on this individual, right? So like, what are you most worried about happening if you eat too much or if you do eat, right? Sometimes the fears can be very variable from person to person, right? And so it's helping to understand what are this person's fears around, right? Is it related more to the fear of weight gain and the change in my shape? Or is it related more to I'm worried that if I eat this specific type of food, let's say ground beef, it feels like when it falls apart that it's multiplying in my mouth and I feel like I'm going to choke on it, right? So kind of helping to differentiate between those diagnoses like anorexia nervosa, where we have low weight due to body perception, right, and body dysmorphia, versus diagnoses like ARFID, right, where there might be some other fear that's underlying the restrictive behavior, right? Next slide, please. So what are things that we should avoid, right? So we should definitely try to avoid shaming the patient or intentionally trying to scare them, right? As the medical provider, we oftentimes will go over, or oftentimes, like, for example, I'll speak with a patient about their degree of malnutrition and why I feel like they meet that degree of malnutrition so they can understand why I'm saying that, right? Because oftentimes some of these youth may feel like there's nothing wrong, right? Like my doctor told me to lose weight, so I lost weight, and now they're telling me I lost too much. So helping them to understand, like, if there are any complications that have arisen, why have they arisen? And what is the patient at risk for if they continue to engage in this behavior, right? So if it's through restrictive eating or whether it's through purging, right? It's helping them to understand that, yes, there are potential medical complications that can be compounded upon like their malnutrition, right? So not only are they at risk for that, but maybe they are at risk for bradycardia, or maybe they are at risk for developing an arrhythmia, or potentially with their purging, an arrhythmia, or potentially seizing, right? And so those are things that we need to be able to relay to a patient, but in a way that's like non-judgmental and just letting you know, like, hey, here's all the details, here's all the information you need so that you can understand like why I am so worried, right? And it's really good to avoid making comments about that person's appearance, right? Sometimes these can be very triggering for individuals. And this is true not only during initial evaluation where you're trying to assess the patient, but also in recovery. As this person is working on recovering from their eating disorder, we generally recommend that families, for example, try not to make too many comments about the person's weight. Sometimes this individual is so defined by their appearance, and they don't have an identity outside of that being the thin, pretty person, that they can't see value in themselves in other ways. So we want to reinforce other positive aspects of that person. And little comments like, oh, you look so much better now, can be misinterpreted when someone has an eating disorder like anorexia nervosa. When a family member says that, they might hear like, oh, you look fatter now, right? And so it's helping to understand, similarly through the use of things like family therapy, like how do I best support my family member, whether it's my child or my sibling or my grandchild or my niece or nephew, right? It's how can I be there for that person in a way that's going to be helpful for them, right? Next slide, please. So when we're evaluating patients, we also want to figure out kind of where are they in terms of insight, right? And readiness to kind of get on the recovery train, right? Recovery is not a steady positive progress line, right? It's not always a positive slope. There can be ups and downs. And things that can be helpful for us are if we know like how ready this person is for recovery, right? Do they see anything wrong with what's going on? Do they want help, right? And so is it that they are looking for help, but they just don't know where to go to get it? Or is it that there's that drive is just not there yet? In which case that's helpful for us to know in terms of prognosis and knowing like what degree of support they may need, right? Next slide, please. So who of the patients that we see really needs to kind of come into the hospital? Next slide. So the patients that we typically admit here at Texas Children's at the downtown campus are patients who have really significant medical instability, right? So patients that have severe bradycardia, so heart rates less than 40s or 50s. We may not always admit someone who's having a high heart rate in the high 40s, depending on their history. Like if they're like a really elite athlete and let's say they have disordered eating going on in the setting of that, it's kind of that in combination with everything else that's going on, right? Similarly for weight, if they're at a very low weight, less than 75% of their expected healthy body weight, right? So we kind of go through their old growth curves and norm them to where they would still be growing if they hadn't lost all this weight, right? Or they lose a significant amount of body weight in a short amount of time, like 20 to 25%, we would say severe malnutrition. Then those are things that we might consider admitting someone to the hospital for. Like if they've just had such acute weight loss, or they've developed such significant medical instability in terms of bradycardia or hypotension, those might be reasons to admit them to the hospital, right? Because they may be at higher risk for developing arrhythmias or pericardial effusions or things as we go into refeeding, right? The other things that we want to look at are syncope, right? And then others, lab abnormalities, right? So if you've seen this patient on an outpatient side, or in a different clinic or even in the ER, like are there electrolyte abnormalities that already exist, right? I've had patients that I've seen as in the hospital who have done so much purging that they've brought their K down to like 1.7, right? And so those are definitely very high risk patients that need to be hospitalized. Similarly, in those settings, sometimes they can develop abnormal EKG findings, and we get very concerned that they would be at risk for an arrhythmia, and so those patients may end up on telemetry. In terms of mood, we also want to be wary of like suicidality. Like Dr. Franklin said, suicidality is very common in these patients, and it's the number one cause of death in patients with eating disorders. And so it's something that we take very seriously in terms of evaluating their mood. And last but not least, just making sure that if they are plugged into care as an outpatient, are we continuing to see progress? Or are they starting to have declines in their health, right? In which case, if they're plugged into an outpatient psychologist and a dietitian and they're seeing a medical provider, and even with that, they're not able to sustain progress, or maybe they're having continued weight loss or continued purging of a significant degree, sometimes that's enough of a reason to admit someone to the hospital. Next slide, please. So what are our goals for hospitalization? It's definitely nutritional rehabilitation, right? This person, if they're coming in not eating meals, we definitely need them to be eating meals that are of substantial nutritional value to be able to sustain some degree of medical progress, right? and that they're doing that consistently, right, without needing a supervision, because we have to be able to replicate what's happening in the hospital when they go home eventually. We want to make sure that if this is a patient who's at high risk for refeeding syndrome, that we're doing what we can to kind of prevent them from going into refeeding syndrome. So starting them at a very low caloric intake and then gradually increasing it over the course of their hospitalization. Typically, the risk for refeeding is going to be highest in the first 5 to 10 days. And so we take those days we watch the patients very closely and get labs pretty frequently. And we also give them supplements like Fosnac to help prevent that as well. We don't see it in a large percentage of our patients, but we do see it frequently enough. Our goal is to medically stabilize them. So if there is any bradycardia or hypotension or lab abnormalities, we want those things to be getting better by the time they've gone home. And then we want to partially weight restore them, right? So our goal for a healthy body weight is somewhere between 90 to 110% of the ideal body weight. And so we want to get them to 85% if they came in, like, let's say at 50% or 65%, right? So making sure that they have enough nutritional buffer that when they go home, if there is a little bit of a rocky course, they don't end up automatically bradycardic again and have to come back into the hospital, right? We also have data from our program, especially showing that patients who get to 85% of that healthy body weight are less likely to need readmission to the hospital, okay? And then lastly, we want to make sure that we get them plugged in with mental health support so they can continue psychological support after leaving the hospital. Next slide, please. So during our hospitalization at TCH, the patients are here a pretty long time. So the average length of stay for most patients is 4 to 6 weeks. We've had patients who stay as few as 2 to 3, if it's like, I'm just here to break a binge purge cycle, and I don't really have any medical instability. And we have patients that have been here months, actually, because they came in just so profoundly sick when they came in, who maybe were admitted to the ICU initially before coming to our service. They get skilled nursing while they're here in the hospital with nurses who have been trained to work with youth with eating disorders. Again, making sure that we're not saying anything that could be triggering or doing things that could potentially be perceived as harmful for them. There's a lot of supervision and monitoring that happens in the hospital. So all the meals are supervised, and if they're incomplete, then we make sure we supplement the patients in one way or another, whether it's through oral supplementation or NG feeding. And then there's monitoring, right? So they start off with bathroom monitoring and 24-hour video monitoring, where basically there's like a nurse standing outside the bathroom, just making sure that nothing's going on in the bathroom, listening. It's like purging or exercising, things that might be harmful for that patient's health. But also some of these patients are just so sick when they come in, we're kind of concerned that if they Valsalva, are they going to pass out, right? And then obviously making sure that parents can be involved as much as they can, right? We understand that there are limitations for some families, and they may be single parent households, and maybe they're the sole breadwinner in that household and they can't be here all the time, but we love our parents to be engaged as much as they can when they're here. And then the youth get individual, family, and group therapy when they're in the hospital, and that continues when they go home as well. Next slide, please. So again, over the course of the hospitalization, what we do is we typically start feeds at like 40 kcal per kilo per day, and we gradually increase the amount of nutrition the youth are taking in, with a goal of weight gain of about 100 to 300 grams a day, or 1 to 2 kilos a week. Gradually, their monitoring is discontinued as long as they're making good medical progress, and that they're able to cope with some of the urges that they have, whether those are urges to purge or urges to exercise here in the hospital. As they develop those coping skills, we grant them more and more privileges so that they can kind of practice being at home, right? In terms of physical deconditioning, oftentimes, like Dr. Franklin said, these youth are started out on bed rest, and then we gradually introduce stretching and walking and then light strength training as well, to kind of keep them conditioned for when they return home. And then in terms of mental health and dietary support, they start meeting with a dietitian first day in the hospital so they can learn how to order meals, and that person is readily available to them anytime they have questions regarding meals or regarding behavior surrounding food. And then they start with meeting with the therapist about 1 to 2 weeks usually into the hospital stay, because our primary focus really early on is medical stabilization. And if they're very profoundly cognitively slowed, it may be difficult to engage in therapy if they're significantly malnourished. Next slide, please. So in terms of going home from the hospital, again, our goal is to get that 85% of that healthy body weight to make sure that they're at lower risk for needing readmission to the hospital. We want them to be able to complete all their meals because we want to be able to create a sustainable structure that's able to be maintained at home. And then we want to have improvement in whatever purging behaviors or compensatory behaviors that were there. We're focused on medical stabilization, so getting those minimum heart rates above 50, making sure they're not hypothermic anymore if they were when they came in, no profound hypotension. And then we set up follow-ups with all of our providers before they leave the hospital so that that's figured out for the family before they leave. Next slide, please. So in terms of the alternatives, like Dr. Franklin had spoken about, there's a lot of these community eating disorder programs which can be great resources for youth who maybe don't meet criteria for medical hospitalization because maybe they're not medically unstable. But again, like she said, they're not readily accessible to everyone, whether that's based on location or them being for profit, right? So if you have Medicaid or if you're uninsured, then unfortunately those aren't options for you usually. Next slide, please. And so in developing a plan, next slide, we're focusing on a couple things. We want to know if somebody has needs for therapy or needs for dietary support, in which case to make sure you're plugging them in right away. Next slide. And lastly, just how do we help at the Woodlands, right? So Dr. Franklin and I both work up there. And so if you have a patient who needs to be evaluated, you can definitely put in a referral for them to see us. They can also see Dr. Franklin for things other than eating disorders, and for me, things other than eating disorders. But usually the first evaluation will be at the main campus just to make sure that they don't need to be hospitalized on the initial visit, because that does happen with some bit of frequency. And next slide, I think that's it. I think there were questions that popped up.
Yeah, I tried to answer some of them. I think one of the big questions that I'm curious about what Dr. Recondo would say as well, is people just saying, what do I do about having patients that are needing care by adolescent medicine and are on our wait list? And this is a problem. We agree. We're frustrated as well. I know someone said my patient has a 4-month wait time and she is on the verge of needing inpatient care. So I'm assuming that wait time is to see an MD. And I don't know what else could be done about that, Dr. Recondo, other than I know that they can sometimes have those urgent visits.
Yeah, so I would say if you're continuing to follow up with that patient between then and the 4 months when they are scheduled for the visit, which I would recommend, as you're seeing kind of like progressive declines, that's times that you can kind of just call us and be like, hey, this patient's really not doing well. Is there any way that y'all can get them in sooner? Because as they start to, let's say they weren't having any bradycardia and they're starting to have some bradycardia, or there's any signs of initial development of kind of some medical instability, those would be reasons that we would offer, like Dr. Franklin said, one of those like urgent care appointments to try to just get their foot in the door and make sure that they're not really tanking and need to be hospitalized right away, and see if we can try to prevent it. But I would say don't hesitate to reach out to the on-call team if ever. Sorry, Dr. Franklin.
No, that's perfect. I think from a mental health perspective, I will be honest that we were telling families about 3 to 4 months ago that it was going to be a 6-month or longer wait list to see one of our psychologists. There were multiple reasons for that. We had a psychologist out on maternity leave who will be returning in a month. We were also in the process of hiring a new psychologist. So we were essentially down 2 psychologists, and we were in a really big bind with that. I do believe our wait list is getting smaller, and I think it should be better. I obviously can't promise anything, but I know we're doing everything in our power to get as many kids off that list as possible. And I mean, I really believe that if a kid has private insurance, can contact me, and I'm happy to send you other referral options. I know that that's more challenging for kids with Medicaid or no insurance, but it's very different, I think, when a kid has private insurance. We do have other options so that they're not waiting.
I think the other thing that I would mention, Dr. Franklin, is sometimes we offer urgent visits to families when we see their initial referral, just because how sick they sound or they look. And sometimes those visits are declined by family members because they have, I don't know, like a test that day or something. And so we just strongly encourage them, like, if we do offer your patient an urgent visit, like if y'all can also enforce, like, yeah, you should definitely take that visit. Like it'd be a great idea, and it'd be really great for you to kind of be able to access those resources sooner rather than later.
Yeah. I do apologize that the wait lists are long to see our physicians and our team. I think that just speaks to like how many kids are in need out there, probably how many more physicians and psychologists that we need in adolescent medicine. I do believe that, hopefully in the near term, we would have a full-time physician up in the Woodlands as well, so that Dr. Recondo isn't going back and forth and trying to work main campus and the Woodlands. So I think things will hopefully change in the near term. If you have a patient that's really in need, and from a private insurance standpoint, I'm happy to do some investigation. We do have a lot of providers in the area that we know of that take kids, but they just are with private practice insurances. Thank you guys so much for taking the time to meet with us and let us talk today.
Yeah, no, that was a wonderful presentation. Thank you to both of you for your expertise and for sharing such great information. And just want to encourage everyone, there are some comments in the chat still, and I'm sure that both Elizabeth and Stephen would be happy to answer additional questions if you want to reach out to them directly about the content. There's
Dr.
one.
Ritondo, would it be possible for you to stay on the call just for a minute afterwards? I have a question about a specific patient I would like to ask you.
Sure.
Thank you.
Thanks, guys. Feel free to get in touch with me if you have any specific questions or concerns.
All right, great. Thank you all.